Thank you for that introduction, and to Sages for asking me to come to talk today. So my name is Kimberly Yee. I'm a colorectal surgeon. I work in a small hospital in the suburbs of New York City, 292 beds, but expanding. And I also happen to be the chair currently following Virginia for the Education Committee for NAPRC. I have no disclosures. Okay, so I think we all know that the care of rectal cancer is quite complex and continuously evolving. And an astute group of people under the name of Ostrich looked at NCDB data from 2006 to 2011, a large volume of patients, close to 31,000, who had stage 2 and 3 rectal cancer. And when looking at this, it became clear that treatment-based guidelines were not really being followed all the time in the treatment of these patients. And when looking at it, there was a huge disparity between hospital volume and geographic location. Similarly, when you looked at NCDB data from 2010 and 2011, looking at over 16,000 patients who underwent resection for stage 1 to 3 rectal cancer, there were positive margins in 17%. When you look at other places such as Europe, this rate is much lower. So I think it became clear that we could probably all be doing a better job over the course of the country. So when you looked at, for instance, in Europe, places have created centers of excellence in order to address and improve the rates for these things that we have noticed. And the goal is to improve both short-term and long-term outcomes for the care of these patients. And when you looked at what were the components that they were considering to improve, these were some of the details that they looked at. Improving the quality of the surgery done by total mesorectal excision, improving the assessment by pathology, improving the assessment by people who are expert in reading MRIs, use of chemotherapy and radiation therapy, and meeting to discuss patients at a multidisciplinary tumor board. So this culminated in the creation of the National Accreditation for Rectal Cancer Program, which is an American College of Surgeons Initiative quality program. All programs are already COC accredited, and this program was first released in 2017, and the details of the current standards can be found listed at that website on the internet. And the goal was clearly to improve the care of patients with rectal cancer. Since that time, like all programs, you can imagine that when the programs are created, they're meant to achieve that goal, which is to improve this care, but they actually need to be achieved by a wide variety of different kinds of institutions, small institutions, larger institutions, academic centers, and private centers. And so there's been revisions of the standards in line with that to make it achievable by a multitude of different places. So the first revisions were in July of 2020, and some of these revisions pertain to things like attendance requirements and such. There were also recent new standards that were released in January of 2024, which when you looked at the program, it was noticed that in the evolution of it, that certain other details were not really addressed, including local excision and watch and wait. And we're going to hear some more about these exciting details pertaining to rectal cancer management later on. So when you look at the standards, just to really simplify it, the program requires that an MDT meeting happens, which means that all patients who are being treated for rectal cancer are seen and assessed holistically by all those different specialties. Also, not obviously clear to patients is that within a program, you have experts who routinely care and look at these patients from the pathology perspective as well as radiology perspective, are making the assessments for both the pathology and the MRI reads, which is really critical because these are important pieces of data that are used to drive the decisions. And then also the timeliness of it is required that you treat the patients within 60 days. So all of those are very basic components that are outlined by the standards. When you look at, if you choose to participate in this program, if you have the program, you need to have a rectal cancer coordinator. So this is a person who helps to make sure that all their compliance between the standards is met, but you can make that what you want. So you can look at your institution and say, you know, what other deficiencies or needs does my institution have? And you can build that position to also, while meeting the requirements of NAPRC, fit those other needs that you have. So there's many different models for how you can achieve this, but it is a resource that if you participate with the program that you'll be able to have. It also creates good communication for organization across departments, which is difficult when everybody's schedules is very busy. This is a point person for both crosstalk between the departments, as well as someone also that the patient directly can interface with if that's how you choose to do it. They also achieve doing the comprehensive evaluation, which is also a necessary requirement for rectal cancer patients. And then down the line, one of the new standards that is being looked at is to perform quality improvement projects, and they can help participate with that as well. So when you look at it, it really does benefit the care of these patients by looking at radiology and pathology and having dedicated people who routinely do it assess the patient with you. So we decided to do it in my hospital, and my hospital is very forward-thinking and enjoys participating in many well-known programs. You have to look at your organization of your hospital and decide how you're going to approach them in order to tell information about the program, to get buy-in from both administration as well as your colleagues who will be participating with you in the care of these patients. So for us, I had to create the position for the rectal cancer coordinator because we didn't have that person before. And I thought that the needs of our program also would fit a pelvic floor person. So our person would also be a person who would do pelvic floor assessments and the care of those patients in our institution. So just to give you a timeline, we learned about the program in 2017. We discussed with the hospital administration in order to create that program, that position. And it wasn't until 2018, about 6 months later, that we were ready to officially present from the beginning to end and be compliant with all the standards, our first patient as part of the NIPRC program. When you are starting out, you need to collect at least 12 months worth of patients in order to be able to submit for accreditation. So when we had done that in 2019, we submitted, and in July we were site reviewed, and then had a couple corrective actions, and were finally accredited in 2020. After that, we were pretty well organized in terms of how the program was running, but as one would expect, different things come up, just as in all regular life, and sometimes people would leave the institution, like a radiologist would leave, and we would have to reorganize how we were being compliant with all the standards, for instance, attendance, and we would have new people join. Someone went on maternity leave. We had to look at our institution and get support in order to be able to meet that need while we recruited another person. And having great communication and really knowing the details of the standard is really critical. I would say the person who takes the lead to become the program director really has to read all those standards, but most people in your institution probably won't read the standards. So I think for us, I think it was very easy to make a flow chart like something like this, where we were able to speak to all the details of what the program said, and then you would have to convey all that to all the players at hand so that they could be compliant with what you needed to do in order to make the program really work. So that's what we did, and we had these two flow charts, and we're able to really convey those details of the program to everyone. So for us, we've been participating in the program since 2017. We actually had some escalation in the number of rectal cancer patients that we've been treating since that time. I think we really have felt good benefit. Like I was saying, I really feel strongly about having known pathologists and radiologists who participate routinely. And I think the quality of the reads and assessments from that is really great. But we all know that assessing the benefits of anything is very difficult. There is a large range of institutions in terms of institutions who are even thinking about becoming accredited, institutions who have actually been involved with really being compliant with the standards even before they were even released, meaning that they were part of the group who created this program. And some programs have looked at a lot of data points, including these that are listed on this slide. So one could look at the value of NAPRC to your institution by all these different things that are listed here. And one of the other opportunities over time will be for programs who are accredited to be able to collaborate to collect some of these endpoint data points to prove the value of NAPRC. But before that, there have been some new data that has been released, actually hot off the press, which do indicate that there is benefit to being part of NAPRC. And this was just recently released like a month ago or so, where it was a retrospective study looking at patients who were treated for rectal cancer between 2017 and 2020, and 3.3% of the close to 2,000 hospitals were NAPRC. And the conclusion of the study was that there was definitely a benefit to the quality in terms of mortality, morbidity, and complications pertaining to centers who were participating in NAPRC. But obviously, this is early data. There was another recently published a piece of literature that suggested that there's a sentiment also from people generally that there is benefit to being part of NAPRC, where basically people feel that there was improved quality and culture being part of this program. So clearly there are barriers getting buy-in and being able to create that position. But I think all in all, I think there is benefit, and we'll look forward to seeing what the future holds. All right, thank you.